Hi, good morning everyone. Welcome to our first collaborative seminar between Singapore Nurses Association, Wound, Ostomy and Continence Nurses Chapter and Coloplast. I'm Corinne, a member of the WOCN chapter, and I'm currently working in the Department of Plastic, Reconstructive and Aesthetic Surgery in KK, and today I'm so pleased to be your MC and moderator. In this seminar, webinar, we'll be learning a lot about skin around the stoma, issues that we faced, and more importantly, how we go about to act to prevent the damage around them. Again, before we start, we have seen the house rules. Do mute your microphone, and if you have any questions, put them into the Q&A function, and we will try to address all the questions as much as we can. I promise you today, it will be going to be interesting. We have two speakers, 2 sharings and 2 video clips that will enhance your knowledge and so that you'll be able to apply when you go back to work. Okay. Our first speaker, without much ado, is Assistant Nurse Clinician Alvin Seah. He's a colorectal resident nurse at SGH with 12 years of experience working in colorectal surgical unit. Alvin is currently part of the healthcare team under the Enhanced Recovery After Surgery program, which is called ERAS. He delivers enhanced care and improved outcomes for patients undergoing colorectal and stoma creation surgeries, hence reducing post-surgical wounds complications. Alvin will be sharing on the stoma and the skin around the stoma. So please help me type W to welcome Alvin. Alvin, please.
Hi, thank you Corinne for the wonderful introduction. Good morning everyone, my name is Alvin Seah and I'm a nurse, assistant nurse clinician currently working in SGH in the colorectal unit. Okay, so so today's topic I'll be speaking a little bit about the stoma as well as the skin around the stoma. Okay, good, now we have the slides up. Okay, right, so we begin. So today we'll be going through quite a few items. So namely, what is a stoma? We're going through the role of a stoma, as well as the different types of stomas and how they can differ in different subtypes as well. We will also touch on the skin, its anatomy and function, as well as the relationship between the stoma and the peristomal skin. We will touch on the stoma and peristomal skin assessment, as well as throw in some further considerations on stoma training, as well as the choice of appliances and accessories for patients with a stoma. And lastly, we'd just like to wrap up quickly with care and maintenance of the stoma and the peristomal skin. So to begin, what is a stoma? The word stoma has its etymology with roots in ancient Greek language, stoma, meaning mouth. But this has been adapted into modern Latin, the word stoma, which means opening or orifice. Now, in the medical term, a stoma is what we consider an opening that connects an internal organ to the surface of the body through a surgical procedure. So these examples of such stomas can be a colostomy, ileostomy, even things like a PEG or such. But today we'll be talking a little bit more about colostomies, ileostomies, and urostomies. So basically within my area of specialty. So the history of a stoma is fairly interesting. The first time a stoma was ever created was, it's very scantily documented, but the first documented one was in the early 1700s, in fact. And then the first documented one was in 1793 on a 3-year-old patient with an imperforate anus. So what happened was this surgeon, because it was the first time they were doing such a surgery, so he practiced on cadavers of infants before performing this novel surgery, first time ever in the world. And the patient reportedly survived to the age of 45. So that was quite a breakthrough back then in 1970, or rather the 1800s by then. So early colostomies were then created in the past, in the lumbar region, as opposed to what we commonly see in the front right now, because this was in the extraperitoneal segment of the colon and did not interfere with the peritoneum, before transitioning into the modern anterior approach, so the more common anterior-based stomas that we see and know today. Now, the first ileostomies were created flush to skin, so they didn't think about making it protruded or anything like that. They just wanted to join bowel to skin and that's it. So it was flush, resulting in a lot of breakdown, a lot of skin damage, as you might expect. So the first protruding stoma was only created in 1912, but this was still a very crude method of creation, where they pulled the length of ileum out of the abdomen, and they just clamped it there and left it there, and allowed it to heal so-called naturally and slough off naturally until it has a auto-maturation through mucosal eversion. And this method actually resulted in a lot of inflammation and a lot of obstruction due to stenosis. But the modern ileostomy that we know was actually created in 1950 by this Dr. Brian Brook. What he did was he surgically everted the stoma and very simply just sutured it to the skin surface. So this not only created a nice sprouted stoma that is above the skin surface, as well as managing to avoid the pitfalls of the previous stoma, which was your inflammations and your stenosis. So that healed quite nicely. So this is the stoma that we know these days. Now, the role of a stoma, in colorectal surgery at least, a temporary stoma sometimes is created to divert stools away from a surgical anastomosis. So when we have a portion of the colon removed and that's joined together, we don't want, ideally, we don't want stools to pass by if, say, the joint has a higher chance of breaking down or having an infection. So this reduces the irritation of the anastomosis, but do note that a stoma does not reduce or avoid the chance of an anastomotic breakdown or leak. All it does is to mitigate any catastrophic complications should a leak eventually happen. Now, temporary stomas can be reversed later on in the recovery with subsequent surgeries. Okay. But sometimes a permanent stoma may be required if, say, the original disease organ is not able to perform its original function. So say if you removed an anus, for example, in a surgery, then there's no way you can join it back for normal, so-called normal function. Hence, we have that stoma to act as a permanent outlet for these patients. Now, broadly speaking, there are three common types of stomas. So namely the colostomy, the ileostomy, as well as the urostomy. So to go into slightly deeper detail, the colostomy is created from the colon, and because of the anatomy, it's commonly created in the left iliac fossa region. But this location is highly dependent on disease location and the intention of the stoma creation. Because of the anatomy and where this stoma is created, stoma effluent or stoma output tends to be semi-solid, ranging from semi-solid to form stools. And this is highly dependent not just on anatomy as well as the diet of the patient. And the effluent, as you can expect, is very commonly odorous as a result. Now, in comparison, an ileostomy, as you can tell from the word, ileo, is created from the ileum, which is the small intestine. Now, this is commonly created in the right iliac fossa, or RIF region, which is the lower right quadrant of the abdomen. But commonly it's there, but again, location is very dependent on the disease location and the primary intention of stoma creations. So through my experience, a lot of these stomas or ileostomies that are created for the purpose of defunctioning, so to divert stools away from, say, a colonic anastomosis. Hence, the terminal ileum or the end part of the ileum is used, and this results in a lower right quadrant stoma. Now, you can expect stool content when passing through the ileum or when it's in the ileum it hasn't had a chance to transform, say, into solid stools yet. Hence, the stoma effluent tends to be a bit more watery to maybe semi-liquid stools. And as such, the effluent tends to have less of an odor, so it's a more mild odor as compared to a colostomy's output. Now, lastly, we have something a little bit different, which is a urostomy. So what happens is when, say, a person's bladder is not viable, or the urinary tract is disturbed in a way because of disease or because of injury. Hence, what happens is the ureters are actually surgically implanted to a short length of harvested healthy intestine. Usually, small intestine is preferred in this procedure. And this intestine is then, one end of it matured to the skin surface to allow or to act as an output for the urine produced by the kidneys flowing through the ureters. So this process bypasses the bladder, whether if it's surgically removed or required to be diverted away for treatment. So now we've gone through the three main stomas. A little bit, maybe we'll touch a little bit more about the subtypes of stomas. So in this, we have a loop stoma. And as you can see, the creation of how this stoma is created, stomas, while you can see it as one bulbous mass on the abdomen, it is not exactly an end of, or rather for these stomas, not exactly just one structure. So what happens is the bowel loop is cut, not fully, but enough to expose two ends of the lumen. So one of the lumen will be called the proximal limb, as well as the other, the distal limb. The proximal limb is where your stoma output or your effluent be flowing out of, and the distal limb is where leads to the anus, down the GI tract. So in the middle photo, as you can see, this is where, as I mentioned earlier, the stoma has been brought up, everted, and sutured down to the skin surface as such. So the appearance will be as seen. And sometimes it can swell a little bit, so like the photo on the right. So it all, as long as you can identify the two distinct lumens that's joined by a continuous mucosal bridge, then this is your loop stoma. Okay, so for loop colostomy, like I mentioned, everted, surgically matured to the skin surface. You can see very much clearly in the graphic on the top right. So in some certain cases, a stoma rod can also be inserted right in between, underneath that loop, to allow better fixation and placement of the stoma, prevent premature retraction of the stoma. And this is commonly mostly found in colostomies, loop colostomies that are created. And this subsequently allows the stabilization of stoma. It is kept there for a few days, typically about 5 days, in order for the mucosa to tack well to the skin and for everything to mature and stabilize before we remove the rod and proceed with further care. So loop stomas consist of course, proximal and distal limb. So the proximal limb is your prominent limb. This produces effluent. This usually is sited right in the middle of the stoma. Central lumen in a loop stoma. Now, the distal limb leads to the rest of the GI tract towards the anus, and sometimes, for some certain surgeons, they may have a habit of creating it either level with the proximal stoma or slightly mildly recessed or tucked underneath the main stoma. So, in order for you to differentiate it better, and also, of course, not to obstruct the proximal limb's function and effluent. So now, moving on to a double barrel stoma, we have something slightly different. So as we are now, instead of a loop where we only cut it halfway through, now we have a double barrel stoma where a segment of bowel in between these two ends are fully removed, and what is left is two viable ends of bowel. So these, for whatever reason, may not be joined together and both brought up to the surface of the skin together in one opening in the abdomen. So this is double barrel stoma. Okay. Okay. Now, a variant to the double barrel stoma is what we sometimes know as a divided stoma. So healthy ends of this bowel are then matured, not in one opening, but at separate sites of the abdomen. And why this is done is because sometimes you have limitations, either in surgical complexity, adhesions, or what we call internal scarring, that may limit the mobility of these bowel lengths, or sometimes certain disease progression, say localized cancer, that may not allow bowels to be moved freely to wherever you desire. So they have to be open inside to at that location. Okay. So this is a divided stoma. As you can see from the graphic on the right, you see that the end colostomy on the bottom right, that one is pouch because that is your proximal limb, and that has effluent and feces coming out of. The other one leads to the anus. So that one, because we sometimes call that a mucus fistula because it doesn't produce any stool other than a bit of mucus, a bit of mucoid discharge. But because it is a connection from one end to another, we sometimes denote that as a fistula as well. Okay. Now this one is an end stoma. So an end stoma is basically just one lumen. Usually, the proximal limb is just brought on its own up to the surface without a presence of a separate stoma or the distal limb. And this can happen in a few situations. Okay. This can happen in a few situations. So one is that, say, the remaining length of bowel is fully removed, so there is nothing to join back. Or two, you may have a situation where the remaining length of bowel is unable to be joined back together, either due to surgical emergencies or disease progression or injury to the area. So this is brought out on its own with the separate end either fully removed or closed off on its own as a dead end. So a creation of end stoma, like a loop stoma, is also as such. So you still bring it up to the surface, you still evert the mucosa, and you still suture it down, except this is just one single lumen, as you can see from the graphic here. Okay? Right. So that is all in all the what we touch about, the brief introduction in stoma. So now we talk a little bit more about the skin. And to talk about skin, we need to understand the different layers, the functions of the skin. So the skin, in essence, is divided into two major layers that sits above the hypodermis layer. So these two layers prominently are the epidermis as well as the dermis. And they all play a pretty interesting function in each of these layers. So the epidermis on its own comprise of the stratum corneum, stratum lucidum, stratum granulosum, stratum spinosum, and the stratum basale. And these different components put together provide different functions like physical barriers, water retention, immune response, as well as pigmentation through melanocytes. And below that, we have the dermis. So this is subdivided into two portions, the papillary dermis as well as the reticular dermis. So the functions of these vary very much widely now because you have a lot of more structures underneath. So these contain connective tissue proteins that provide structure, strength, and elasticity to the skin. They contain fibroblasts. This is to synthesize connective tissues as well as to create and maintain the extracellular matrix within the skin layer. They have mast cells and macrophages to serve as an immune response to any invasion, as well as a very dense vascular network full of arteries, veins, capillaries, and whatnot. And not to forget, within this layer, there's also other epidermal appendages, so other sort of add-on frills. So we have hair follicles, sweat glands, sebaceous glands, etc. And all this in a neat package on the image to your right. You can see how it fits all in the skin. Now the functions of skin there are many, but here's a few that we can highlight to you. So first and foremost, the skin serves as a thermoregulation structure and regulates cutaneous blood flow. So, you know, sometimes vasodilatation and vasoconstriction can happen very often. That's where you have hot flushes, or patients look cold and clammy. The skin color sort of changes a little bit. So this happens so that the skin is able to sort of regulate the blood flow as well, in turn regulate temperature onto the surface. And with the layers above, it not only regulates it, but maintains the temperature right there. So together with adipose tissue layers, it is able to insulate and keep the skin temperature at a constant without big fluctuations when exposed to the environment. Now, the skin also provides immunity because not just a physical barrier against pathogens, but they also have antimicrobial peptides that are abundant in the skin surface. So this reacts to any pathogens that invade the skin. And to survey and to sort of say go for these, we have a lot of these things called Langerhans cells, and these actually activate the phagocytic action of macrophages towards all these foreign antigens that invade inadvertently to the skin surface. Now, not to forget, we have sensory perception. The skin, of course, there are a lot of receptors in the skin, and that detects touch, pressure, temperature, and pain, etc. And of course, as a barrier, it prevents excessive moisture loss to the environment. So that keeps your skin and your cells beneath well hydrated and healthy. And last but not least, we have vitamin D synthesis when exposed to sunlight, or UV rays in that sense. So now, what happens when we have a stoma next to a skin then, or what we call peristomal skin? A normal skin pH typically can range quite widely, but we look at it probably between 4.5 to pH 6, which is a little bit more acidic on the pH scale, as you can know. 7 is neutral. Anything less than that is acidic, anything more will be basic. So this acidity is actually maintained from the protective acid mantle that the skin maintains in all throughout. Okay. However, stoma effluent tends to be a little bit more basic in nature because of all the digestive juices, the enzymes, the food that's taken in. And this can be about 7 plus, 8, and tends to be a little bit more basic. Hence, this can be liquid stools from the ileostomy, or urine, in fact, from the urostomy. And because of the fact that ileostomies and urostomies in particular continuously discharge effluent, it's not like a start and stop, or go and whatnot. It puts out whatever contents it has. There is no gate or sphincter to control or have a little bit of continence in most of these stomas. Hence, if left unprotected, prolonged contact with exposed skin surface can result in damage of the skin layers, and hence, in turn, disrupting skin function, resulting in moisture loss, invasion of pathogens, etc. Therefore, we will see in a lot of papers and a lot of places reporting that actually peristomal skin conditions are very common. It's a common ailment that a lot of patients face, and with one review study actually seeing that early post-op peristomal skin complication rates can rise as high as 45% in all patients, and this is for early post-op. In certain other studies, for longer-term chronic issues, up to about as high as 80% of all patients do experience some issue or another in their lifetime wearing a stoma. So it's something to think about. Now, when we look at the stoma as well as the skin around it, so how do we then have a good look or assess it properly? So there are some gems that I just want to share with everybody. So on inspection, a healthy stoma typically should appear as such. So we have I've broken them down into a few sub headers. So we have the mucosa. First, we look at the stoma itself. So mucosa color should be deep red, should be consistent around the area. There should be no dark patches or areas of pallor that may indicate issues with circulation beneath. Now, protrusion and stomas should be nicely sprouted above the skin surface, ideally. This is to allow better pouching to prevent inadvertent leakage of effluent onto the skin surface through stoma that is not so ideally sprouted. And of course, to do that, the lumen should be ideally in the middle of the stoma, sitting at the center, so that effluent can be properly managed. And we also want to look out for any complications around the stoma. So things like early complication can include edema, bleeding, and later on you can also have ischemia as well. Yeah, okay. Now, mucocutaneous junction should be intact. So this is where the skin meets the stoma, should not be separated. So we also sometimes may see the sutures that are present from the surgery. Okay. Peristomal skin should be intact with no signs of inflammation or injury. And also we look at any presence of contours in the abdomen as well as skin folds that may influence your pouching technique. Now, lastly, we look at effluent, which is the volume and characteristics that are appropriate for the stoma type, as I mentioned earlier. So we want to manage a difficult stoma. Sometimes we don't have a say or choice in how the stoma looks or how the stoma is created, sometimes due to limitations in the surgical process or disease progression. So hence, it is a clear obstacle to ideal pouch placement. So we want to reassess the stoma from time to time because these situations may change, and we may want to see if there's any additional techniques or appliances that may be required to achieve a good skin barrier or good seal. So we are looking at all these photos. You can, again, back to the key things that I was looking at earlier. We want to look at whether the stoma is retracted, whether the output is appropriate, whether there are deep contours or any skin folds around the area or hernias that may influence this. Whether the appliance is suitable for this patient and his stomas, as well as the competency in applying this stoma, be it the caregiver or the patients themselves. Okay, so linking on from that, we want to make sure that early education of stoma training starts before the surgery, in fact. And this gives patients and caregivers a baseline knowledge and manages their expectations on what it's like to have a stoma, to live with a stoma, to care for a stoma. And this should not be a journey that the patient does alone. So engage as many relevant people as you can, patients, families, caregivers, to mentally prepare for this. We want to make sure that it's not a touch and go or single session thing that once I'm done with. So it has to be active participation and engage them, both patients and family, to be more invested in the stoma care, because a good self-care ability is associated with better quality of life, better adaptability to any changes, better empowerment of patients, as well as preventing readmissions and stoma complications in the longer run, which is key, I think, for patients wearing a stoma. So when we train patients and caregivers for stoma care, we want to include the following. So do we introduce the stoma appliances that are available in the market, as well as explain the benefits and drawbacks of these commonly available accessories, and teach them how to apply the stoma appliances appropriately, as well as request a return demonstration if they're doing this on their own, to ensure that their skills are well done, basically. Okay, now we want to discuss as well on activities and dietary intake while one person has a stoma, and we want to outline what is suitable, what is not so suitable for these patients, and also discuss appropriate dietary intake, as well as how find adjustments on how they can influence their stoma output a little bit better. And of course, we want to leave them not on their own, but also with some relevant support resources. So hotlines or services that they can engage in the time of need, let's say if they need to refer to somebody for a stoma issue. Now, choosing the right appliance for the stoma may not be as straightforward. So we want to consider a lot of things. Look at the houses on the side. You can see the one on the top left is a nice, pretty house, very, very typical looking house on a nice flat plane. So that's very ideal. But what if you have a house on a hill? Or a weird looking house that hangs over a big drop off on the hill? Or the one on the bottom right, I don't think that even looks like a house. So it looks a bit something from out of this world. But stomas are a little bit similar to that. They don't typically have a very standard look. But once you consider the contour type of stoma, the choice of appliance as well as the location of stoma, and consider the financial constraints of patients, then you can choose the right appliance for this patient's stoma. When we talk about technique in pouching, we have two main types of pouching systems. So the one-piece system, which is typically cheaper, more flexible, and has a lower profile and less visible in clothing. Or the two-piece system, which has a little bit more function, allows to rotate, change the pouch without changing the wafer, and enables the use of a specialized stoma belt for these bags. But they tend to be a little bit more on the pricey side. Okay. So some other appliances that can be used in tandem to stoma pouches are as such. So we have things like stoma belts, flexible tapes that stuck around the wafer, strip paste, seals, and powders and whatnot. So these can be all used to increase the adhesion as well as to prevent leakage of the stoma and keeping the stoma bag on for longer. Okay. So these are some other accessories that we might have as well. Okay. And lastly, just to finish up, we want to talk a little bit about the care and maintenance of the stoma and the surrounding skin. So in general, when you tell your patients, you should advise them to empty their stoma bags when they're about 1/3 to at most half full. Half full, I say just empty it directly and immediately, don't wait any longer. If not, it may burst. Change your stoma bags at regular intervals or at first sign of deterioration. So if you see like a leak is about to happen, you see the wafer is saturated with moisture, it's about to give, then I think it's a good idea to have a stoma change at that point before it actually leaks. At the same time, it's a good idea to use adhesive removers to prevent skin injury, or what we call medical adhesive related skin injuries, MASI. So this can be taught to patients and healthcare providers to make it a habit to use this regularly. Okay. We want to be able to cleanse the stoma and the peristomal skin with something that is not very harsh. So water is our go-to. Together with a gentle soap, if patients are actually washing this in the shower, yes, they can actually shower with their stomas exposed, provided it is well matured and healthy. So a gentle soap with water, that's fine. Or a suitable non-rinse cleanser can be used to clean the stoma and the peristomal skin. But it is important to avoid using alcohol-based products for routine cleaning because this can be very caustic or very harming to the skin. It is important to also dry skin thoroughly before applying new pouches and new appliances. Wet skin doesn't tack very well to our products or our skin barriers that we see. So dry it well and remove as much moisture as you can and protect the skin, of course, which is our next point. Use a good skin barrier spray or skin barrier wipes to protect your skin. Apply this invisible layer that protects skin from effluent exposure, and then before putting on your pouch. And last but not least, we have make sure that either caregivers, healthcare providers, or patients themselves inspect the skin regularly for early detection of skin damage. So this can be as little as, say, a little itch or a little bit of skin pain here and there, but it is important for patients to identify these signs early. And I think that brings us to the end of my session. Thank you for your attention. So I would like to hand my time back to Ms. Corinne. Thank you.
Thanks, Alex. Well, looks like you have covered quite well about the introduction of stoma and what are the expectations for the patients and the caregivers. We have two questions which actually was covered probably in that range of presentation by Alex, but nonetheless, Elvin, there's a question for you which is quite related together by Shuna, Misu and Alex. They're asking about the stoma assessment too. How frequently do we actually need to do that? I believe it's when you are inpatient, during inpatient time.
Well, with the stoma assessment tool, because there are the stoma is a dynamic structure, and it's not something that once you set it in place, it stays the same way forever. So I would advise every time you are able to see the stoma in its full glory, so to say, whenever you do a stoma bag change and a good cleanse, you're able to look at the stoma and assess the stoma properly. And that should be done as a habit, so that the more you do it, the more familiar you are at picking up complications, and the better you are at it eventually. Yeah.
I hope that answered the question. We have another interesting question that is from Mr. Pubalan Rajagopalan. Hi Elvin, this is Mr. Pubalan. Jude here. May I know what is your technical consideration for giving fleet enema via stoma?
Wow, okay, this is a bit of a curveball. Okay. But well, in my experience in providing fleet enemas through stomas, it is not as simple as putting we're quite familiar with the bottle with the little spout. It's not as simple as just pushing the spout into the stoma. The rigid spout will actually hurt the stoma and cause a bit of ischemia here and there. So very often what we do is we introduce a catheter of sorts. So we use a Foley's catheter, which is nice, soft, flexible, well lubricated, and inserted in full length before administering. But before this, administering the fleet via the stoma, we must assess the stoma and understand why this fleet is being given in the first place. So say if, what is the cause of a fleet? Usually you want some stool output to be coming out. So patients might be experiencing some form of ileus or some form of decreased stoma output. Hence, you must understand also what the fleet is for. So it wouldn't be any good, say, in an ileostomy where the fleet does is it draws water and it irritates and it pulls the contents out. But in an ileostomy where there is not much, say, volume or storage, then that is not too viable. It will be better functioned in a colostomy in that sense. And then you want to assess the stoma properly as well to see if there's any localized, say, stenosis, any blockage, any obstruction in the, just what your finger basically can assess in that end before inserting and delivering the fleet enema. Yeah, I hope that answers your question. Yeah.
Since we are on this topic, maybe I get the second speaker just to put in her input to add on to Elvin's reply. Do you advocate the use of enema on the stoma?
Not by any general nurses actually. We do need the doctor to examine and make sure that fleet enema is indicated first. And it has to be done by a trained ET nurse. Not any nurse is supposed to do it, because if there's any abnormalities as mentioned by Elvin, then it would not be very appropriate for any general nurses to do it and hold the responsibility.
Thanks, Magdalena. She'll be the next speaker that will be coming up soon. But meanwhile, I have a question for Elvin. You have mentioned a lot about the stoma and then preparing patients, the family, the carers, and the responsibility that they will be facing in the future, whether it's be a short-term stoma or long-term stoma. So to me, CGT is, or rather caregiver training is very important component of a patient having this to embrace the condition first, and then suddenly to say that okay, you're going to have a stoma on your body. So that, to me, that is an alteration of our body image already. So what kind of training or time span are given to this CGT over a period for them to get acceptance prior to surgery?
Well, so prior to surgery, I think it starts at, in fact, either at diagnosis or even before diagnosis, when patients first see their surgeons and understand that they have a condition that requires them to have a stoma in the short or the longer run, that's where they should be engaged by an enterostoma therapist. So to talk a little bit more about what entails carrying a stoma, what the accessories are like, and basically the lifestyle changes as well as the social changes that may come into play when you have a stoma. So in our practice at least, we have models and we have like a bit of demo kits that we do provide to patients to either try out a fake or a false model stoma on their abdomen and paste a bag on so that they can experience what it's like to have a bag at least before a real stoma is created, so they can manage it with their clothing or their lifestyle and make adjustments accordingly. So this paired with good education beforehand is also allow not just the patients but the family members caring for these patients to have a mental preparation of what's ahead, what's to come. And I think lastly, it is also for family members or for patients themselves to sort of finalize and sort out things like caregiver issues. Where is the patient going to be after discharge, after the surgery? Who is going to be the main caregiver? So all these things can be discussed and can be identified well in advance of surgery, so to allow a more smoother recovery or transition to having a stoma and discharge and beyond. Yeah.
Thank you. So you would say that there's actually not really a time essential period, or because some of the surgery should have been done within a certain span of time?
Well, for elective surgeries, I would say I think at least a 2-week period leading to would be a good minimum time frame, but sometimes you have situations that don't allow us the luxury of time. So in emergency surgeries, in urgent surgeries. So with those cases, then we will augment that with more intensive training, caregiver education, and follow-up. But whatever we can prepare, I think that will be very useful for the patients and the caregivers moving forward.
Okay, thanks, Alvin.
Thank you.
One short question, this will be the last question for Alvin. Any skin inflammation and what is the prevention you will take? When do you anticipate this?
Okay, so I think at least within this topic, skin inflammation is very, very commonly influenced by the exposure of the skin to the different elements or the different effluent, fluids, moisture. So it's important at every stoma bag change, firstly to do a good cleanse, a good gentle cleanse, and assess the skin properly before applying the next appliance or the next treatment if need be. And to prevent skin inflammation, what we would advocate is the use of a proper skin barrier, as well as prepping and drying the skin properly before each application. So the skin barrier, while it is naked to the eye, you can't see, you don't know if it's really working or not, it does provide an invisible barrier, invisible layer that holds back this direct contact with any stomal effluent, which is very caustic to the skin. And I think day-to-day habitual tips you can also share with patients is like, say, after showers, if the stoma bag is wet inside, outside, it's a good idea to dry them off with a towel before moving on with your day. And also just to maintain good airflow, good moisture management around the area. So loose-fitting clothes, nice circulation. I think that's definitely going to help with the skin condition.
Thank you, Alvin. Okay, please do keep your questions coming in the FAQ function mode. We will try to answer you live, or if not, we'll type in a response to you. Meanwhile, we know that a common issue of living with a stoma, with a peristomal skin complications is an obvious challenge. So let us now watch a short video of end users who has been living with peristomal skin complications and how it affects on their lifestyle. So probably that will help answer some of the questions that may be in the registrants who is currently listening in. Enjoy the video.
Je kijkt eigenlijk al met balen en angst naar het volgende verschoonmoment tegemoet.
Nemůžu prostě vykonávat ty svoje aktivity, které mám naplánované, všechno se to poposouvá.
Jeg er tilbageholden med at gentage eller optage mit normale gamle hverdagsliv med masser af træning.
Mijn naam is Karen Sangaert. De lekkages en de huidproblemen, toen die heel heftig waren, helemaal niet meer zitten. Ik vond niks meer leuk. Ik was helemaal lam geslagen. Ik durfde de deur niet uit. Dat ik op een gegeven moment echt heel erg depressief daarvan werd.
Jeg hedder Mathilde. Jeg oplever oftest, at mine hudproblemer og lækage har sammenhæng til hinanden. Jeg føler mig begrænset af at have de her hudproblemer i forhold til netop at tage svømmehal med min datter og gøre ting, som jeg tidligere har gjort.
Jmenuji se Anna Penkerová. Tím pádem, že mám takovýhle problém, nevyhledávám nikoho.
Het heeft een enorme impact op je als mens. Je voelt je afgesloten van de buitenwereld. Je neemt geen deel meer aan de maatschappij, zo voelde het.
I hope you enjoyed that educational video. We know that the effects on quality of life for ostomates living with peristomal skin complications are very significant. I now call upon our second speaker, Assistant Nurse Clinician Madiliana, or I call her Maddie, who is a colorectal nurse in CGH. She has 36 years of experience where she provides clinical management for patients who have colorectal issues, as well as being involved in the planning, developing and training, conducting for healthcare personnel as well as caregivers in the colorectal stoma wound care. Maddie will be actually sharing more on the maintaining of a healthy peristoma skin, preventing and managing peristomal complications. To you, Maddie.
Okay, good morning to everyone. Welcome on a Saturday morning to spend time with us. Thanks Corinne for the kind introduction and Elvin for sharing on what is a stoma. So now will be the more important role, as in how do we maintain the peristoma skin. Oops, sorry, some glitch. Okay, so how do we maintain the healthy skin? Okay, so I will be covering people with stoma living with peristoma skin complication. Peristoma skin complication with irritant dermatitis and one of the 4 moisture-associated skin dermatitis. Okay, mechanical trauma, assessing peristoma skin complications, how to prevent and manage them, and some other case studies that we have at the end. Okay, so leakage and skin complications are still the biggest problems for people living with a stoma. About 77% of people living with a stoma have experienced leakage within the last month, and 88% of people using ostomy products have peristoma skin complications. So it does have a negative impact on quality of life. 1 in 3 people who experience leakage and or skin complications cannot do light activities. They can't even change plans, do not want to see other people, and they rather stay at home. So the type of peristoma complications are irritant contact dermatitis, mechanical trauma, infectious dermatitis, mucocutaneous separation, pressure ulcers, folliculitis, allergic contact dermatitis, pyoderma gangrenosum, pre-existing conditions like eczema and psoriasis, and many others. So we try to cover as many as I can. Now, 2 of the most common peristoma skin complications are the colostomy and ileostomy. As you can see, most of them have encountered irritant contact dermatitis for both 40% for colostomy and 54% ileostomy, as well as the others. Okay, so this is the irritant contact dermatitis, and this is how it looks like. Okay, it can become very serious like this, or a mechanical trauma without the use of some chemicals to help remove the appliance. Okay, so the two types of contact dermatitis, from irritant, where the penetration into the skin causes the inflammation, which we call a non-specific reaction, or allergic reaction to the that really causes an activation of the T cells resulting in the inflammation, which is what we call a specific immune response. Okay, so the peristomal dermatitis is a type of moisture-associated skin damage, which we call MASD for short. For peristomal dermatitis, we put it as a PMASD. Okay, so for the moisture-associated skin damage, it occurs when excessive moisture leads to inflammation of the skin with or without erosion or secondary cutaneous infection. And moisture can come from multiple sources, not only from feces and urine, but perspiration, wound exudate, mucus, saliva, as well as other secretions. So from the picture above, we'll be covering about the peristomal dermatitis. Okay, so for the peristomal dermatitis, the skin erosion or inflammatory response is caused by exposure to the output on the surrounding skin of the stoma. So it also refers to the skin underneath the base plate. And this liquid, which we call the proteolytic enzymes, is present in the stoma, which causes this irritation. So the source of this irritant or moisture includes the feces, the urine, intestinal mucus, perspiration, wound exudate, and external sources like patients still can use the ostomy appliance and go swimming, bathing, do some sporting activities as well. Like this, okay. So the signs of the peristomal dermatitis is reflected on the pictures below. So you can see an erythema or inflammation around the stoma. And the skin is often damaged by prolonged exposure to output accumulated under the base plate. The skin is less tolerant to prolonged stress and mechanical peeling. So these four are the common types that you will see. Okay, the factors that affect the peristomal dermatitis, the two common ones are the output properties and exposure to ileostomy and urostomy. Mostly liquid and loose stools, contains digestive enzymes that can damage the skin moisture barrier, contains bacteria that can cause an infection. For the urostomy, it's liquid, it's always continuously coming out. The pH value range from 4.8 to 8.0, and high pH, which is alkaline, the urine is extremely corrosive to the skin. So the other factors, as I've already mentioned earlier on, so with the seal between the base plate and the skin, if it is not good, and the wear time, which is supposed to be from 3 to 5 or 5 to 7 days, if it is used longer, have an increased risk of resulting in the PMASD. So for mechanical trauma, it's actually skin stripping, okay, when you remove the appliance, or pressure on the skin, sometimes from the stoma rod or stoma key, or shearing, okay, from the, sometimes patients like to pull, stretch, okay, over the area. Assessing the peristomal skin complications can vary from a mild, erythema, a moderate erythema, or a very severe erythema as seen on the picture. Okay, the other many factors that contribute to the risk of these complications will be like, how well does this product fit the patient's peristomal body profile? How much attention is paid to the burden of experiencing leakage and peristomal skin complications? How easy is the product to apply and remove? how is the availability of the right product to meet the need of the patients, and what are the regional guidelines for stoma surgery, and what is the patient's family and friends support network. Okay, so for us, the prevention and treatment of peristoma skin complications is continuous care from healthcare professionals when they require, identify peristoma body profile, and ensuring a good fit of ostomy appliance. Not just apply, but make sure it's the correct, appropriate product. Have a structured skincare solution and change routine to keep the skin dry and intact, as well as an education on the proper use of ostomy care products. Experienced peristoma skin complications was surveyed on a total of 4,235 patients, and 73% actually reported skin issues. And the drivers of these skin complications are leakage under the base plate, which showed the highest results, followed by age, stoma type, the time since surgery, the gender, the wear time for 2-piece base plate, and wear time for a 1-piece device. So leaking under the base plate is the primary cause of these peristoma skin complications. Just look at this, where the liquid flows beneath and go under the barrier, and you can see the liquid actually accumulating below the base plate, resulting in a skin irritation. So the right fit to peristoma body profile is crucial. So a poor fit to the peristoma body profile is the main cause of leakage and skin complication. So remember, the right fit to body is the key to preventing any skin complication. Okay, so how do we ensure the right fit? Is by using this assessment tool called the RIO. R for regular, where the skin plane is flat with the stoma slightly budding or protruding out, where we can use a standard base plate and a seal to help with even out any super creases and folds. I is for inward, okay, where the peristoma is below the surface of the abdomen, and sometimes it creates a hollow effect. You can use a convex plate, which is will help to even out the skin flow, the skin fold, and below the skin surface. The next one will be the outward, which is the stoma is protruding out, like what we see in a peristomal hernia. Okay, this is so that they can use a normal standard base plate as well, but you realize on the edges of the wafer, we can cut slits, and we use tapes, stoma belts to help to conform to the shape and edges of the stoma and prevent it from lifting up or rolling. Okay, next is the structured skincare solution. So you remember these 3 acronyms, which is the CRP: cleanse, restore, protect. When we cleanse the area, depend on your area of availability. Normally, some places don't have the luxury of using a non-rinse skin cleanser. You can use normal water, warm water. You can use wet wipes as long as there is no perfume or irritants to irritate the skin. And then you need to make sure that you dry the skin first. Once it is dry, you apply the ostomy powder. The ostomy powder is to ensure that moisture is absorbed. Maybe not now, later when they perspire or do any activities, it can help to absorb the moisture. But remember to sweep off any excess powder. And before you apply your appliance, make sure you put a layer of skin barrier film, because it will help to form a breathable barrier film over the powder just above your wafer. And then we also can use these seals available. They can come in a form of a ring, a paste, or a strip paste. It depends on the profile of the skin at that moment. Okay, so the next is how to keep a peristoma skin healthy. The next acronym you will learn will be the ARC. That means every week you must diligently follow the apply, remove, check routine. Once you do it, okay, you will be able to maintain a good skin profile. Okay, so every time when you apply, you do a better job of protecting the skin around the stoma against any output and irritation. So a correct appliance change routine starts with the proper application of stoma appliance. You will have the base plates. So you remember the first slides we showed earlier on where we have the regular, okay, inward, outward. So you need to see whether your stoma is R, I, or O. Okay, then you need to have a protection over your skin. So we always use, depending on what you call it, a layering or crusting method. So we always use ostomy powder and a skin barrier. Some places they actually use this tetra polymer barrier film where they don't even use the powder or the spray. There is no wrong. There's always a right in any skin protection. And you also add on the seals if the body profile is not level. You use that to level the skin out. Okay, and you can enhance the security of the wafer by using tapes like the C-shaped tape, the straight tape, or even a micropore tape. We try not to use Tecoderm because Tecoderm is waterproof and the skin cannot breathe. Okay, so we try not to use that. We also, when we remove the wafer, we want to prevent mechanical trauma, so we try to use products like the adhesive removal spray to protect any fragile skin, especially those paper skin that is like paper-like. Okay, now skin irritation for always. Sometimes you see output on the skin in the same place that is irritated or red. So does patient have irritated or red skin that can be caused by cleaning or appliance removal? As mentioned earlier on, yes, it can happen. And most of the time, sadly, because of knowledge deficit, people thought by reinforcing all these appliances, it will help protect the skin. But actually, it results in more skin irritation. Okay, so this is the common one from the previous survey that has been conducted. Majority, 70% of the patient will experience irritant dermatitis. So what is it? It looks the patient will definitely tell you it's very painful. It looks red. The skin is irritated, causing a rash-like picture that you can see on screen. This is always caused by the outer layer of the skin that has been damaged and is easily irritated. So the contact with the body fluids or chemicals like the adhesive pouch material, ostomy paste, powder or soap, wipes, all used on the skin. So leakage due to poor pouch sealing and excessive wear time. As I mentioned, if ileostomy or urostomy, you can use 3 to 5 days. And the colostomy, you can use up to 5 to 7 days. So you need to identify the cause. What is causing the skin irritation? And then give a good cleansing and then select the correct profiles pouching system. So means the profile you see whether do you need a convexity plate or a standard plate. Okay, and then whether you need to level the skin up or not necessary. Okay, then the next one is allergic dermatitis. Okay, so which is a hypersensitivity to the inflammation. So they start with leakage and then the erythema or pruritus will be shown. So you can see it's actually the shape of the wafer. Okay, so you know it's an allergic reaction to it. So we need to remove the identifiable cause. So we get the doctor to confirm and get a tropical corticosteroid or hydrocortisone cream or Becnovate cream. You can apply over the area. So what you need to do is make sure you clean the area, apply sparingly first. Okay, then once it dries up, then you can do your layering method and your seal before you apply your wafer. Okay, if you're going to put too much of the cream, it will not stick. Okay, so the other one is the candidiasis. So same thing, it also causes in the skin reaction to the allergen or irritants as shown. So remove the identifiable cause, use the same topical corticosteroids, okay, contain the effluent, make sure it doesn't come in contact again, and eliminate any unnecessary products, okay. The next one is the caput medusa, or we call Peristomal varices, normally found in patients with liver problems like portal hypertension, intermittent spontaneous profuse bleeding from the peristoma area. You can see that there are ages like a sunburst, tortuous veins around the stoma, okay, and then the varices always bleeds easily from minimal trauma, even like contact with the pouch, okay, or when you touch it accidentally, or erosion. So how do you manage this? Unfortunately, if the portal hypertension is not eradicated, which somehow with liver cirrhosis and all that, it can't heal, we only know how to manage it. So we try to use a two-piece system and make sure the flange doesn't drop on the dilated vessels. Teach them how to apply stomahesi powder, okay, to stop the bleeding, apply local pressure for the moment, and seek medical attention. Do not just manage on their own. Okay, so pyoderma gangrenosum, you will see it as like blood blisters that break to form ulcers at the bottom. Okay, and you can see the rugged overhanging edges with purplish edges, and it's very painful. It's a rare ulceration, but we don't know from where. Sometimes it's related to disorder of the immune system. About half of the people with this PG have underlying chronic health conditions. So we decrease this inflammatory process and maintain appliance seal, give a topical systemic steroid, and then dry the ulcer with calcium alginates and hydrocolloids, then apply the pouching system. Okay, next one will be folliculitis, more for people who are quite hairy and they have infected hair follicles. Okay, so we manage this with antimicrobial powder, cover the large area with non-adherent dressing, remind them to try and shave the area once they remove the appliance, and then and also try to use adhesive remover and sealant so that it will not irritate the hair follicles in those areas. Okay, so this one is more for patients with urostomy where they have the pseudo-verrucous lesion hyperplasia. So it appears like a wart-like appearance. And then it's always caused by the overexposure of high pH alkaline urine. Okay, so normally we assess the equipment used and make sure that it fits the aperture, okay, resize if necessary, and in severe cases, we might need to do a debridement of the tissue. Okay, now, as mentioned earlier on, I'm showing you a picture here. What do you think this is? Is it irritant dermatitis or caused by mechanical irritation? Definitely not folliculitis. I don't see any hair there. Maybe allergic to some chemicals used. Okay, sweating could be a combination. Okay, or a pre-existing skin disease. So what would you do? Okay, so remember when you remove, you see the skin profile first. Is it the flat plane? Do you need a convexity? Are there any variables involved? So the same thing, you clean, okay, do a layering or crusting method, apply some seals if you need to, and the correct appliance. if the skin is very tender, you need to use adhesive remover to help on the removal. Okay, this is the next one. The same thing. When every time you see a patient, you change, you remove, right? So when you remove, you look at the skin again. Is it irritant dermatitis, a mechanical irritation, folliculitis, or is it an allergy hypersensitive to sweating or pre-existing? So same thing. By now you all remember, make sure the skin is clean, remove any irritants to the skin, okay, and then use the appropriate appliance. Okay, same as this. Okay, so the next one, okay, will be, these are all the same pictures I've shown you. They all the same application and method. Okay, so now you have a skin like this, and you see some redness around the stoma. So you clean the skin, you apply the seal. Okay, make sure you do not cover the defunctioning colon, because sometimes it is so small that it's hidden below the stoma, and then every time you paste the wafer, it doesn't seem to stick because there is actually another colon that is hidden right below there. So when you put the seal, be careful. Okay, another one is, what happens if there's an ulcerated area next to the stoma? What do you do? Okay, you can actually apply an alginate dressing to the ulcerated area. Why? Because it will lock in the moisture, okay, and not macerate the skin. So you apply the paste. Now remember, when you apply the paste over the area, don't just apply exactly over just that area. You need to have an area of 2/3 more than the dressing area. Then you apply the pouch. Okay. So we have this patient who come in on day 1. This patient has ileostomy and ileoconduit. Okay, so ileoconduit, you realize there are a lot of variables, skin folds, creases, and all that. So we got a convexity. So they are quite straightforward. We level the skin, but the skin irritation on top, the area is quite big. So I actually introduced a protective skin barrier, which you all can actually try to use. It actually protects the skin, okay, before you apply the seal and your wafer. Okay, so it heals after. Okay, so on day 8, you realize after I did that, day 4 is lighter. By day 8, the skin has already healed. Okay, the next one is, this patient has a prolapsed stoma, and then not on top of that, it keeps leaking at the side, okay, resulting in the whole area being having some irritant dermatitis. Not only that, because of this irritant dermatitis, he also have this fungal infection, because he used to tape and then he cover and keep the area like that. Okay, so what I did is, actually we push in the stoma, the prolapsed stoma, okay, treat it with providine iodine. Remember to dilute your providine iodine, don't use concentrated. Then after that, we apply the protective skin barrier. I use strip paste and whatever seals I have to level the skin. Okay, then after that, I will pouch the area accordingly. Okay, so sorry. Okay, so by day 4, you realize the skin is lighter. I did the same thing again, and then by day 8, the skin has already healed. Okay, so this is another patient. He seemed to have reaction to some chemicals that they were using. Okay, so resulted quite a very bad erythema. Okay, some allergic reaction. So when day 1 we did the same thing, by day 4 it started to dry and flake off. It looks quite scary. Okay, but we continue and maintain the same way of applying all the appliance. By day 12, you realize the skin actually healed very nicely. Okay, so this is another patient whose skin was very badly irritated. Okay, so we were a bit perplexed, because like the skin is all raw. How are we going to put the paste? Because nothing was going to stick on it. So we used a strip paste. So because straight paste is a bit firm, it doesn't melt down very fast. And then on top of that, we use some soft paste, and we use an alginate skin barrier dressing to support our wafer. Okay, so after same thing, about 8 days, the skin actually did heal. Patient was quite happy, didn't complain of any pain. Okay, so this one is actually, the stoma is actually quite small, and the wound started to dehisce at the side, and the doctor removed the stitches, and when it removed, he still say, I still want the stoma to be pouched, but can you protect the wound? So we were like, okay. Initially, I pouched it above the wound, but it leaked. So we decided to use a post-op pouching system and protect the wound from above within the pouching system, and it did help. So I protect the wound, and then I managed to able to isolate the stoma. It's a bit of art and craft, but you must know the products, the body profile, okay, and how to maintain the skin healthy, that you are able to maintain a healthy peristoma skin. Okay, so in conclusion, providing quality care for the person with an abdominal stoma requires attention to clinical care, quality of life issues, and cost. Okay, so if you maintain it well, they don't have to come out a lot of money, and time is also saved for patient. The condition of this peristoma skin in this matrix that we have shown earlier is significant because compromised tissue leads to increased care, health-seeking activities, and problems with adjustment and increased costs. Therefore, a comprehensive approach to preventing and managing these peristoma skin complications begins pre-operatively, as mentioned by Alvin earlier, and continues until the stoma can be closed or for the rest of the person's life. So, access to knowledgeable care providers like us is a key to decreasing complications and minimizing their effect. Okay, so thank you. Back to Corinne.
Thanks, Maddie. That was a really intensive, detailed explanation and practical. You can visually, practically think and go through the steps that Maddie has shown with us. Again, she has managed to show us the different type of peristomal skin conditions and the type that can be caused leading to leakage of output. Before we answer all the questions that's really shooting into our Q&A, may I request that those who put their questions in the chat group, please transfer your questions into the Q&A function. Thank you. Meanwhile, this is your second video that will actually capture what Maddie has actually spoken on. Enjoy.
Leakage is a common issue for people living with a stoma. Actually, 77% experience leakage, which can have a negative impact on quality of life. 8 out of 10 patients only recognize leakage when the output is visible outside their base plate, while in fact, any output that touches the skin around the stoma is leakage. Leakage is when output seeps under the base plate, when it covers most of the base plate, and when it leaks out from the sides. Even a small amount of output around the stoma is leakage. Any amount of leakage can cause skin complications. Peristomal skin complications can affect the adhesion of the base plate, which often leads to more leakage, creating a vicious cycle of leakage and skin complications. Finding the right product solutions and change routine can help prevent leakage and skin complications to break the vicious cycle. Prevent leakage and skin complications by establishing appropriate change routines. Apply, remove, check can help do just that. First up, apply. Proper application can ensure the skin is protected from stoma output and the skin complication it may cause. Always make sure the base plate is applied to clean and completely dry skin. Cut the hole to fit the size and shape of the stoma. The key is to make sure the base plate has a snug fit, not too loose and not too tight. If it is challenging to get a snug fit, it may be beneficial to use a supporting product, such as a seal. Remember, the stoma can change size and shape over time, so it's important to check it regularly. If the skin is moist or needs extra preparation, supporting products such as powder or protective spray may also help. Next up, remove. A gentle removal technique will help to protect the skin around the stoma. Pull down the removal tab to loosen the adhesive from the skin. Gently remove the adhesive by rolling it step by step downwards, while applying light pressure on the abdomen with the other hand. An adhesive remover can provide a little extra help. Finally, check. Checking the skin and the adhesive can reveal if the change routine is appropriate. Check if the adhesive is eroded or if there's any stoma output on it. Then, check the skin around the stoma for signs of redness or damage. Using a mirror can be helpful. Healthy skin around the stoma should look the same as the rest of the abdomen. If there is a feeling of discomfort, itching or burning under the base plate, it is important to change it, no matter what the routine is. If there are signs such as erosion of the adhesive plate, leakage on the base plate or the skin, irritated or discolored skin, it may indicate that the product should be changed more often. Life is more comfortable with the right change routine.
Hi, welcome back. So I hope that the video on leakage and about the ARC is very clear to you guys as a summary of what Miss Maddie has spoken. The floor is now open for you to bombard her with all the burning questions that you have on peristomal skin complication. Don't hold back. Give it to her. Okay?
Okay.
Maybe I'll start with one question. This is very interesting because I also have this. If a patient is allergic to the plate and the patient refused to use it, what advice would you actually give to the patient, Maddie?
If it's truly an allergic reaction, I need to confirm it with the dermatologist first. But we do have other brands that we can actually share with the patient. So with their approval, we can also do a skin patch test first, okay, and see whether the patient, to seek the patient's trust that this particular appliance will really work before we show the rest of the products available. So,
okay. The other questions that keep popping up, we noticed there's been 4 or 5 similar questions, is asking about the use of sterile water or normal saline to do the cleaning of the stoma. We have answered like on text, but maybe one of the panelists would like to address this question again.
Okay. So with stomas, you realize that the effluent and the output is actually mostly fecal or urine. So if it's urine, if it's a urostomy, then it is a good idea to use a sterile or at least a clean solution, so a cool boiled water at the very least, or just water for irrigation is fine to cleanse the surrounding area. However, if you're working with stomas, colostomies, ileostomies, then actually normal tap water, it will suffice. So you don't need anything too over the top. Yeah.
Another question. Who are this group of patients who are still able to perform strenuous physical activities? Are these people with stomas? Can they be actively doing sports?
oh, they can be actively doing sports. We actually have a cancer survivor, a few of them actually. I have a cancer survivor who is actually a trainer. Another one who is a freelance. He appeared on TV a few times. His name is Iliu. He has crossed the Gobi Desert twice. He is doing a lot of marathons. Okay, he may not be the fastest, okay, but he does have the endurance. All my cancer survivors, especially in my support group, they actually meet up pre-COVID days where we actually go outdoor. We go to the reservoir for walks, we go hiking, we go to the beach, but the numbers are limited right now because of COVID, the last one that we went, we were allowed a maximum of 8 participants. So the group of 8 went around walking around the Pasir Ris beach. Okay, you also can do other activities, but approach your nurse, ET nurse, to advise what type of support binders that you can use during your sporting activities. Swimming is also allowed, badminton, a lot of the activities you can do. But before you embark on any activities, make sure that you get clearance from your doctor first to see that you are fit for your these sporting activities. But with any appliance, stoma appliance you use and a proper support appliance, you will be able to embark on a very normal life. Okay?
So I suppose it's how they adapt
That's
back
right.
to the activity of
Yeah,
daily
that's
living.
right.
Yeah? So
Yes.
this is where they get good supports from family and
Yes.
friends. And the next question we have is, where can I get a big protective barrier which you have showed in your image? And can you explain how you dilute the povidone iodine and its usage intended in this scenario? What alginate dressing do you use?
Normally, I'll use, there are 2 particular brands that I will use, okay, for the alginate dressing, which is, one is either the biotin or the Aquacel dressing, okay, with the silver inside. But there is no particular brand that I favor, okay. You can use either alginate dressing. The protective skin barrier, I do not know in your institution you have. My institution, we have the big one, okay, so we cut it to size according to the fit of the profile that is required. Okay, but what about your side? Do you have the big profile, or yours is the smaller one, or you don't have it at all?
We do have the 10 by 10s, the tiny ones, but we also have the bigger sized ones as well in different styles. So like you said, we cut the shape, cut the size, and then we apply, especially for contours and irregular stomas.
That's right.
I think when it comes to wound, I mean, besides, I do more wounds than stomas. I only tompang to do stomas when I have to. Wounds, we look at skin all the time. We look at the nature of the problem that we face first before we actually decide the type of dressings. The armory you must have in your department first. You must have a wide range so that you can fit into whichever skin that you look at for that day. So you apply accordingly and then you secure the pouch over it. So there are many dressings, in fact, more than what Maddie actually has shared. So again, it depends on the institution and the department and the kind of wounds that they have. So they have all the armories of dressings to use per individual patient. And then again, like you said in the slides, weekly checks, assessment tools and things like that. That one has to be very critically followed through with compliance, so that you manage the skin. As it improves, you change the type of different dressings that you may require until you get a fully epithelialized skin underneath.
Yeah, that's right.
Any other questions? We found that it stopped at okay, Maddie. This is from Lim Siu Hong. Thanks for the comprehensive presentation. Could you provide advice in terms of appropriate diet? And before we answer this appropriate diet, I think we did not answer on the dilution of iodine. So maybe you answer the iodine first before you go into the diet.
Not your side, how you all dilute it? Because I try to dilute it like 1:10%. Yeah, I dilute it in that form. You don't use concentrated because it will really burn the patient's skin. Yeah. So it depends on your organization, because some comes in diluted form as well. So yeah, you need to see your organization which form of providing iodine you're carrying. I mean, in our side, some we don't, not only provident iodine, we have others, like even we use acetic acid or whatnot. Dilution is actually directed by the doctors also. So we have to work very closely with the surgeons to before we embark to proceed with what kind of cleaning solution we need to use and the protective solutions that we need to apply. I hope that answered the question. Okay, diet, my interesting topic. in my side, my surgeons will always tell patients you can eat anything you want. But I always tell patients that your guts never ask you for MC. You know, we like to ask for MC so we can rest, right? But your intestine cannot take MC. So what happens? So we always tell patients, take small, frequent meals, okay? But at least for the first 2 to 3 weeks, go slow on fiber. Because fiber, if not taken, if they take in large amount and insufficient fluid, can cause intestinal obstruction. So they need to chew first many times, okay? So if they chew and it bulks up into a thick residue, okay, spit it out, okay? If they chew it and it can break down into small pieces, then swallow it. But always go slow, take small, frequent amount. Don't go, and then try food one at a time. Don't one day go on a buffet, and if some food irritates you, you won't know which one caused the irritation. So after post-op, go slow, take small frequent amount, take sufficient fluids because we don't want you to get constipated as well. So at least a minimum of 2 liters of water unless contraindicated. Okay, if not, you can ask more from your dietitian also. How about you, Alvin? Anything to add on?
No, I mean, like you mentioned, we talk about small frequent meals, we talk about low fiber. But I think one more important thing to patients is once they have such a drastic change, or they perceive to have a drastic change in their diet, it's important to remind patients that while you should avoid high fiber foods and whatnot, there is still a wide variety of foods that patients can take or can try in order to whet their appetite. So we don't want to end up restricting the patient to the point where I don't feel like eating this, I don't feel like eating that, and then they don't have enough nutrition, which is key for healing, recovery and all that. So discuss with them their normal dietary habits, what do they usually eat, and then sometimes they'll realize, hey, I can actually eat this, I can actually eat that. So have a good chat for patients with your nurses, or if you're nurses yourselves, have a good chat with your patients to share with all these possibilities, the different types of foods that you can take.
Yeah, but we do have a small percentage of patients that they really want to eat, but they really post-op don't have the appetite to eat, okay? Thereby, we try and help them by calling the dietitian in, because then we can order supplements during this period of time of recovery, so that once they recover, they can go back to eating the diet that they want to in small frequent amounts, okay?
Still again on diet, have you experienced patient with low stoma output or constipation? And how would you actually treat that?
Well,
okay. For us is we always reiterate to patients, make sure before they go home they drink sufficient fluids, okay? And then we also check on their effluent, their output. Most of the time, the patient, when we see them 1 week after they get discharged from hospital, they will most of the time do not have this issue. But as I said earlier on, there is a small percentage. Now, the constipation always happens from those patients who have poor fluid food intake, and that's where they become constipated. And also mobility. They go home, they literally lie down, they don't move. They need to do minimal at least 30 minutes of exercise a day, okay, not 30 minutes an hour, 30 minutes a day. So with any movement, it results in the peristaltic action of the guts, okay? If they go down and you realize constipation only happen on patients who are bed-bound. Yeah, so that's why I say have to have sufficient fluid to prevent that constipation. If constipation really do happen, then we'll take history like how many days is it? Because if it's a short period of time, we still can get the doctor to review and give them some laxative to take. Okay, if not, the last resort will be the evacuation using, as what Alvin mentioned earlier on, using a fleet enema. Okay, but that is a last resort. Yeah. What you want to add on, Alvin?
No, I think so. All those points, yes, and I think it's quite important for patients, especially when they have a new stoma, for them to go home and keep a stoma diary. So this entails them actually recording like the volume of stoma output, what they eat or what they drink across the day, and how much actually comes out through stoma, through urine. The more detail, the better. So they have a better picture of what the food dynamic in their body is like. So they can truly then see, what actually constitutes a constipation, because what their idea of constipation before a stoma and after a stoma may be very different. Yeah. So a record like that is always useful, not just for the patient, but for the enterostoma therapist that's tending to them if they flag up this issue. Yeah, so I do implore to all of you all, if you have patients like that, do encourage them to keep a diary that is in this sense.
Yeah, I believe so. Whenever you have cases or wounds like this or conditions that has a change from your daily activity, it's always good to keep a journal. Then you can present it to the nurse or to the doctors whenever you come for visits or when you give them a call. I have to close this interesting and very dynamic Q&A session so that we can move on to two nurses who have actually taken the time and effort to share with us two stomach pictures, images about the challenges that they actually face in their daily practice. So the first case sharing I'm inviting is Miss Feng Ying. Feng Ying, are you there? Oh,
okay,
hi there, Feng Ying.
Yeah.
Feel free to start now.
Hi. Oh, okay. So I have this boy. He's a 21 years old. Okay. He has this PEG and ileostomy created in 2013. So he's quite young since he has these stomas lah. Okay. So the PEG tube has been removed last year, and he coming in multiple times because of the skin irritation, skin issues around the peristoma areas. So you can see his stomach actually is a very irregular shape and it's like flash skin. Okay. So what I do for this patient is, of course, we cleanse the skin. Okay, we use povidone iodine to prepare the area, and ostomy powder, barrier spray. Then we use stoma paste to even up the skin surface, and use the convex base plates to pouch the area. Okay, but the issue is the pouch not able to last that long, so it always have leak after 2 days or 3 days the most. Okay, so I want to ask whether is there any better ways we can address this issue, so reduce the patient's readmission rates. Yeah.
Cleanse the area, right? And then you already assess the variables around it. Okay, so you already level up the skin. Now the issue is it doesn't stick long.
Yes.
Okay, so when it doesn't stick long, is it because of the initial period of treatment? Because the initial period of treatment, the skin is quite whippy. So subsequently, when you do the changing, does it always leak or it still maintains?
Okay, so when it's like the first time do the change, right? So do the routines. Then after maybe 1-2 days and approach to the second days, the ward nurses or courses that can help the leak again. So when it comes to do the skin preparation again, actually we can see that the skin compared to the first visits, right, is improved. Yeah. Then after that, we reinforce to the nurses that says that we need to make sure the patients go and empty the pouch regularly. Okay. Then also when we just change a pouch, right, just make sure the patient put their hands on their stoma there for a longer period of time, don't come out immediately. And also keep on telling to the patients is that you need to empty. Okay, you cannot wait for the nurses come to look for you or the things lah. Okay, so after the follow-ups visits, right, the wafer seems like able to stick a little bit longer, but of course after that patient will be discharged and back to wherever the environment he has. Then he will come back maybe in a month's time again, the same issues. Then the doctor will cause ask for orders, says that ask the nurses to review any suggestion.
Yeah.
So it's like back to the square one.
Okay, I applaud you for doing the right thing. Okay, so you already inspected, you clean, you level up the skin, you use the correct base plate, okay, which is a convexity. Okay, if you want to, you can actually use the protective sheet. But if you do that, it might last longer. But as I say, because remember Elvin mentioned earlier about the dermis and epidermis layer. Once it's damaged, it tends to whip a lot of mucus. It will come out a lot of serum discharges. So that's why it affects the contact of the wafer sticking to the skin. So that's why I always use the protective sheet. Okay, if you don't have access to protective sheet, yes, be prepared for the wafer to just take 2-3 days. But on the positive side, the skin did heal. Okay, so with proper cleansing and protection of the skin, yes, eventually the skin, dermis and epidermis layer will heal. And you did do the correct way. Okay, there is nothing to fault your treatment plan. It's actually quite good. Okay, yeah.
Thank you.
Yovi, you want to add on anything, or you're okay with it?
I think I'm okay.
Yeah.
Yeah.
Yeah, okay. Thank you, Feng Ying, for sharing.
Okay, thank you.
Thank you.
Thank you.
Okay, we can move on to the next sharing, which is actually from Jing Yi. This time she's actually under training for wound and ostomy at Ng Teng Fong Hospital. I forgot to thank Feng Ying, who is actually resource specialty nurse actually from CGH. Yeah. So can I call Jing Yi now to show us what is it that she want to share with us?
Hello. So this case is Madam KK. She's 90 years old. She had a T3N1MO sigmoid rectosigmoid adenocarcinoma. So she underwent a laparoscopic converted to open Hartmann's procedure in 2016. And she had an ankylostommy at the left lower abdomen. So the body profile assessment tool, when she came over, when she was admitted, right, she had an inward and variable form. The abdomen was soft. There are superficial creases at 3 and 6 o'clock. And the stoma is below the bending line. And the stoma was below the surface of the skin. So she was producing thick and hard stool at the time when we saw her lah. Yeah, and when that time we saw her, she had a peristomal erosion at the and surrounding skin in view of the pouching failure. So upon probing much more, then we found out that the son has never learned how to change the stoma. So it was usually the helper who changed the stoma for the patient. But the previous helper, she left already. Then there was a new helper who came for 1.5 months, and she was quite forgetful lah. Yeah, so that's why there's a pouching failure also. So the management for this patient is we clean the peristomal skin with wet wipes and easy cleanse for easy removal of the fecal material on the skin. Then we apply stomaadhesive powder, barrier spray, and also stomaadhesive paste around the stoma, as well as the skin creases at 3 and 6 o'clock. Then after that, we pouch the stoma with the 2-piece convex base plate and the transparent bag. And we also did a CGT with the son and the helper. So I have 3 questions. The first one is, why does the stoma retract? Then what are the management in Singapore for stoma retraction? And also, how would stoma retraction affect the bowel output?
Okay. Thank you for your case study and your sharing. So first, before I answer your questions, I just want to comment that the management that you've actually undertaken to take care of the stoma, I think it's good. So you've taken extra effort to cleanse the stoma as well as prep the skin properly with your powder, your sprays, your crusting method to ensure that the skin has a nice tacky surface to put your appliances on. So now to answer your question, the first question is, why does a stoma retract? I think there are many factors in terms of why a stoma may retract. But looking at your patient profile. She's had a surgery before that was meant to be a laparoscopic surgery, but converted to an open. So I'm not sure about the details of the surgery, but sometimes this denotes that there may be some hiccup during the process of the surgery, either an emergency or technical difficulties. Maybe they're unable to mobilize the bowel, or maybe they're unable to access the proper organs that they need to access properly or safely. So as such, the stoma that's created may not be as ideal as expected or as the surgeons wish. So it may be under tension or because it's not being able to free up properly. And then tension is a big part of why stomas retract. So over time, as it heals and as the wounds retract, it pulls back into the abdomen. So this also can be compounded with ischemia, stenosis, and gives a lot of problems down the road for patients, especially if they want to be able to pouch, prevent leakage, and so on. So how do we manage a retracted stoma? Then how do we pouch it? At least in our practice, what you've done is correct. We want to make sure, first and foremost, to create a good seal around this stoma. It is much harder to do so. If you throw back to my presentation where I talked about old stomas that were not created, sprouted, but flushed to the skin, had a lot of problems with those in the olden days. So what we want to do is to protect the skin. And then sometimes in addition to your powder and your sprays, you may also consider, like Mehdi was mentioning earlier, including a protective sheet as well around the areas where the skin may be a bit more eroded to better protect and to better prep the skin surface. And then on top of that, use of a suitable convex wafer would be key in order to press down and push out the stoma as much as possible, as well as minimize that space between wafer and skin. So we will prevent the leakage as such. On top of that, it will be always a good idea if you can include a belt in the securement of these convex wafers, because the convex wafers push downwards onto the abdomen, which has a tendency to push back. Where you push something, something pushes back. So you have the belt in order to secure and hold it down in position, as well as tapes and whatnot to secure it firmly. Make sure that these tapes are safe for the patient, because the patient already has skin damage. So make sure the skin is well protected beforehand. And sorry, what was the last question?
How would stoma retraction affect the output?
Okay, stoma retraction and output, actually not so much. Output, like I mentioned earlier in my talk, was different stomas tend to have different quality, different consistency of output. And this is influenced by the anatomy, as well paired with what you eat, and as well as the prevailing prevailing intestinal function at that point of time. So what you get is always going to be what you get at that point. However, because of the presence of a retracted stoma, which is not sprouted, it's hard to pouch, it is hard to exclude effluent from flowing all over the place, then your challenges are mostly to be able to protect the skin well, to contain fecal matter or effluent in its intended pouch or intended collection system. And then also take in consideration that these systems that you employ are going to be cost effective, are going to make sense financially to the patient longer term, as well as make sense to the caregivers. We mentioned there's a new helper that may be struggling with a lot of complicated systems to manage over a longer period of time. So constant engagement with the family, the patient, the family, and their caregivers is key in order to understand their needs, understand the level of competency that they are at, and then to follow up with them regularly so that they can adopt whichever working system that you've prescribed and follow through with it successfully, so for long-term success. Yeah.
I think on my point, because I always like to look patient in a holistic view. This is a 90 years old lady. I believe it's a lady, in case I missed that. Yeah, so the whole responses that Alvin has given you, actually, we must also look at the age, the person, whether or not they have the mental capacity to understand what they are going through, and then again the carers, how are they adapting to the care that is required for this lady? Because let's say, for example, if she has dementia, or she's the kind that is a bit, I wouldn't say violent, but who cannot express themselves well, but they use hands and mouth and everything, that is the added value of challenge actually in handling a stoma. Yeah, and with that, I would actually like to extend another question. How do you actually make a choice of looking at the stoma, the use of convex and concave pouches?
Convex and concave. Well, if you're looking at just the stoma itself, so convex and flat stomas, basically. So
Standard
stomas. Yeah. So, of course, if the stoma is nice, sprouted, very ideal, very classical textbook looking stoma, then yes, I would favor the flat stomas. The flat wafers. Oh dear. Yeah. But if, say, the stoma tends to be either retracted, as you've shown us in this case study, or if the stoma is sitting, say, within a skin fold or within a contour that is amenable to leaking once you put the wafer on, then you might consider either, number one, putting on a convex wafer with your securement systems, so with your tapes, with your belt, and that hopefully will help to push the stoma and bring it up to the surface a lot better while sealing the skin around with the adhesives well. Now, this has to be augmented with what the patient is open to, whether they are able to, say, change this, with the level of dexterity or technicality, or if, let's say, financially they have some constraints, because a two-piece pouching systems with all the gamut of accessories is definitely going to be much pricier than a standard one-piece stoma pouch with a basic accessory, a basic paste or whatnot. So this conversation must be held with the patient or the family members to understand what their ability is like, what they are open to, before we recommend certain things to them. So it must be a two-way, a good discussion to decide on these factors.
Maddie, you have anything to add?
You realize with age group, the skin fold tend to be more, especially at the belt line area where you showed just now at the 3 o'clock and 9 o'clock. So when they do the pouching, sometimes it helps when the patient is seated. Then you can actually see where the skin folds are. And that's where you apply the strip paste or whatever seals you have to level up the skin. Because as you grow old, they lose the collagen and whatever fats they have, and the skin starts to sag. And when they sag, it's very pendulous, So that's why you need enforcement like the belt and all that. But then again, this patient may be a patient of dementia, with dementia, and they might pull. So if they spend so much money on every appliance we have the best we have around, and they always keep pulling it off, pull the back off, pull the wafer off, and then resulting in the skin, the effluent to leak out and irritate the skin around it. So yes, as what Elvis say, you need to speak with the family, their comfort level, the patient, the quality of the patient, okay, the whole holistic thing. So maybe sometimes a one-piece system is better, certain clothing, a lot of things come into effect. So you might need to use minimal products, in fact. For this patient. A lot of consideration.
Holistic care, like I said.
That's right.
We have to look at the person first, the disease, then the skin, then the stoma.
That's right.
How I always go in that area. So this is just sharing from us, from the wound team and stoma team. Now we deviate a bit back to the question. Again, an interesting on the use of iodine, the dilution again is being brought up, questions, and then how we know what's the indication to use iodine on the when we are treating the skin before we pouch the stoma.
You realize I don't use as first level of treatment. I only try and use everything I have. Okay, the one that we use is the crusting or layering method. If one layer, if it's prophylaxis, okay, but if the skin is irritated, you only can do up to a max of 2 to 3 times. Because 2 to 3 times, after that, if you try to do more layering, the skin tend to smooth out. Then your appliance can't stick on it. Okay, it will glide off. Okay, but now we also have the other one where the tetrapolymer, the magic wand, where you also you can use that. Okay, but it depends on your area. But the iodine I only use as a last resort. Okay, and the dilution again is according to what your institution have. Okay, because some comes diluted, some not, and then you have to ask your institution what is the dilution, because if I tell you, it might not be the same. Yeah.
So you have to go back to your team, your surgeons, to decide on what kind of a solution to use. Because there's many in the market, and or rather there's some very commonly used and they suffice already.
Yes.
Yeah. For Vidon, I think it's only at the extreme when we really need to use it. Otherwise,
I will never choose it as a first line of protection. I'll only do it as a last line.
So another question here, going far back again to the first speaker. Last questions, how do you manage patients with hairy skin, with chronic skin problem, pre-surgery? Any advice on that?
Well, that's I think
I would shave, honestly. I'll ask permission to shave first.
So don't shave the entire abdomen, just whatever is relevant to all the things that you need to stick on. But with shaving, I think a lot of guys will experience this also. With shaving, you always try and shave along the grain, not against, and then moisturize the skin before and after. This is to prevent any potential skin damage, as well as potential ingrown hairs and whatnot down the line. So you have folliculitis, as you see in Maddie's slides. We want to avoid these problems. But we need to also prep a skin area around the stoma that you can put a stoma bag on. So stoma bag is not going to stick on hair, especially if you have a very hairy patient. So it is important just to prep the necessary areas and protect it well. And then at every bag change, you can see whether you want to put a new one or re-prep it again.
So, thanks Feng Yi with your sharing, and all my panelists. I think we had a very good discussion here today of value. So could you, before we go, as you know, all good things must come to an end. I'd like again to thank the panelists, Maddie and Alvin, the sharers, Feng Ying and Jingji, for showing us their slides so that we can bring home and then see what we can do with the patients whom we have in the wards. March, a reminder, March is actually the Colorectal Cancer Awareness Month. So do pledge your support and help create awareness by wearing blue for the date on the 19th. Okay, and also if you can, hashtag OASCCAM on your social network. Once again, thank you. Before we go, can you please do a short survey, post an event survey by scanning on the QR code that is now on screen, so that we know what else would you be interested to learn in the future. Again, I'd like to say thank you to everyone, Singapore Nurses Association and Coloplus, for making this collaboration effort possible, our speaker, and to every single registrant who has stayed on to now, and for sharing actively in us our session. My apologies to those who put in their questions at the in the chat group, because we cannot toggle and answer that for everybody else to get to see the answer. So till then, I'm Corinne, and goodbye.
Bye.